Case-based questions on HSV-1 and HSV-2. In this video, we'll quickly revise what we have learned in the HSV-1 and HSV-2 tutorial. Link is in the description below. Let's begin. Case 1. A 3-year-old boy is brought to the clinic with a fever, irritability, and painful oral ulcers. His parents report that he refuses to eat or drink due to pain. Examination shows erythematous gingiva, multiple vesicular lesions on the lip, tongue, and buccal mucosa, and cervical lymphadenopathy. Question 1. What is the most likely diagnosis? Option A. Herpangina, Coxsackie-A virus. B. Primary HSV-1 Gingivostomatitis. C. Hand, foot, mouth disease. D. Stomatitis. Answer: Primary HSV-1 Gingivostomatitis. This presentation is classic for primary HSV-1 Gingivostomatitis, which is common in children. Coxsackie-A virus or herpangina typically affects the soft palate and tonsils, while aphthous ulcers are usually isolated. Hand, foot, mouth disease presents with vesicles on the hands, feet, and oral mucosa. Question 2. Which nerve ganglion does HSV-1 establish latency in? Option A. Dorsal root ganglion. Option B. Geniculate ganglion. Option C. Trigeminal ganglion. And option D. Sacral ganglion. Answer: Option C. Trigeminal ganglion. HSV-1 remains latent in the trigeminal ganglion, reactivates as herpes labialis or cold sores. HSV-2 establishes latency in the sacral ganglia, leading to genital herpes recurrences. Question 3. What is the gold standard for diagnosing HSV encephalitis? Option A. MRI brain. Option B. CSF-PCR for HSV. Option C. EEG. Option D. Sang smear. Answer: Option B. CSF-PCR for HSV. HSV encephalitis affects the temporal lobe and is diagnosed by CSF-PCR for HSV DNA. MRI shows temporal lobe involvement and EEG may show periodic discharges, but PCR is the most specific and sensitive test. Case 2. A 25-year-old woman presents with a painful genital rash, fever, and dysuria. Examination reveals multiple painful vesicles and ulcers on the labia and perianal area, along with inguinal lymphadenopathy. What is the most likely diagnosis? Option A. Syphilis, Treponema pallidum. Option B. Chancroid, Haemophilus ducreyi. Option C. Primary genital HSV-2 infection. Option D. Candida vulvovaginitis. Answer: Option C. Primary genital HSV-2 infection. This is a classic presentation of primary genital HSV-2 infection. Syphilis presents with a painful ulcer. Chancroid causes a painful ulcer with suppurative lymphadenopathy. Candida presents with itchy white discharge, not vascular lesions. Question 5. What test confirms HSV infection? Option A. Gram stain. Option B. Dark field microscopy. Option C. Viral PCR or direct fluorescent antibody DFA. Option D. Urethral culture. Option C. Viral PCR or DFA. HSV is diagnosed using PCR or DFA from the lesions. Sang smear shows multinucleated giant cells, but PCR is more sensitive. dark field microscopy is used for syphilis. Question 6. Which antiviral is preferred for suppressive therapy in recurrent genital herpes? Option A, acyclovir. Option B, valacyclovir. Option C, ganciclovir. And option D, ribavirin. Answer option B, valacyclovir. Valacyclovir is preferred due to better bioavailability. Acyclovir is also used, but ganciclovir is for CMV and ribavirin is for RSV and hepatitis. Case 3. A 5-day-old newborn presents with lethargy, fever and seizures. The baby was born via vaginal delivery and the mother had a history of genital ulcers during pregnancy. Question 7. What is the most likely diagnosis? Option A, bacterial meningitis. Option B, neonatal HSV infection. Option C, congenital syphilis. And option D, toxoplasmosis. Answer option B, neonatal HSV infection. Neonatal HSV infection can cause disseminated disease, encephalitis, or mucocutaneous lesions. Diagnosis is confirmed by HSV PCR from CSF or vesicular swabs. Question 8. Which medication is used for neonatal HSV infection? Option A, acyclovir. Option B, valacyclovir. Option C, ganciclovir. And option D, fluconazole. Answer option A, acyclovir. IV acyclovir is the treatment of choice for neonatal HSV. Case 4. A 32-year-old nurse present with a painful vesicular lesion on her right index finger. She reports a burning sensation, mild fever and localized swelling. She has a history of frequently treating patients with oral and genital herpes. Question 9. What is the most likely diagnosis? Option A, paranoia. Option B, herpetic Whitlow. Option C, cellulitis. And option D, phelon. Answer option B, herpetic Whitlow. This is herpetic Whitlow, a painful HSV infection of the fingers, commonly seen in healthcare workers exposed to oral or genital herpes. Paranoia is bacterial and affects the nail folds, while cellulitis or phelon are deeper infections with different presentations. Question 10. What is the recommended management for herpetic Whitlow? Option A, incision and drainage. Option B, oral acyclovir. Option C, topical antibiotics. Option D, surgical debridement. Answer option B, oral acyclovir. Unlike bacterial infections, herpetic Whitlow should not be incised due to the risk of viral spread. It's managed with oral acyclovir for severe cases and supportive care like pain relief, avoiding lesion rupture, etc. That wraps up our HSV-1 and HSV-2 case-based MCQs. How many did you answer correctly? Let's know in the comments below. Next up, we'll be covering HSV-3 or varicella zoster virus VZV. Got a topic request? Drop in the comments. Like, share and subscribe.